Thank you, Chairman, for the kind word. Thank you, organizer. Always a pleasure to be in Diabetes India. So I'm sure, although I have missed the previous presentation, but I'm sure, you have heard a lot about oral semaglutide. My topic is not on oral semaglutide alone, but it's a GLP-1 entire basket. Do GLP-1 hold promise in diabetes? It's a needless question to ask. All the guidelines in the world give GLP-1 as a first line drug. So where is the debate? Why wasting time? The point is whether which and when which GLP-1 should be preferred in people with diabetes and cardiovascular. That should be the exact question. Hold your nose directly, not indirectly. So I thought that to take GLP-1 entire basket into perspective, you need to ask few important questions to answer that. So this is the agenda. The first hitting question, hard hitting question is which GLP-1 receptor agonist, first line drug in people with type 2 diabetes with high cardiovascular risk, which GLP-1 has best evidence? When I'm saying best, it's not only glucose control, it's not only body weight, but both. Second is, how is oral sema? This session is sponsored by oral sema, but no slide belong to oral sema people. How is oral sema compared to rest GLP-1? Through the RCTs. I always look at the RCT because that's the highest hierarchical evidence for any molecule. And then we will also try to look whether oral sema competes with the injectable sema. You know the injectable sema, so popular drug named Ozempic and Wegovy, started with Elon Musk. So we don't have injectable sema, Ozempic and Wegovy at the moment, but can oral sema compete with the injectable sema? And finally, cardiovascular benefit of GLP-1. So let me take one by one straightforward. Which GLP-1 has best evidence in terms of HbA1c, body weight, and both? So to answer this question, you need to look at the head-to-head trial of GLP-1 conducted in the past. Recently, we looked at those RCTs that compared head-on, and we published last year. You can see there are 7 randomized head-to-head control trials that compared GLP-1 with each other. This is a busy slide to make you this, a schematic presentation. Look at the result. So on your right hand side is the baseline, left hand side is baseline HbA1c, and right hand side is the body weight. You have got the 7 trial in front of you. 3 trial, Pioneer 4, 9 and 10 was conducted with oral semaglutide, where they compared oral semaglutide to injectable liraglutide and injectable dulaglutide. The last 3 is, as you can see, is the SUSTAIN program, 3, 7, 10 injectable semaglutide compared head-on to dulaglutide or liraglutide or exenatide LAR. And the middle one, you can see the award 6 trial that compared liraglutide to dulaglutide. So that's the 7 head-to-head trial conducted to date. And what is the result? If you look at the HbA1c drop on your left hand side, in the Pioneer segment, you can see oral semaglutide beats other 2 GLP-1 head-on. Even if you go to the body weight reduction, oral semaglutide beats other GLP-1. This includes Novo's own injectable liraglutide as well as dulaglutide. When you look at the green bar, that is injectable semaglutide, that is Ozempic, in their 3 SUSTAIN program, you can see there is the largest HbA1c and body weight reduction with injectable semaglutide. So this head-to-head studies, 7 studies suggest that injectable semaglutide and oral semaglutide has the best HbA1c and body weight reduction. So the next question then comes, how about oral semaglutide compared to other drugs, not only GLP-1 into this basket? So Manoj has already shown you this data. We published last year looking at all those 10 Pioneer program. I'm not going to detail, no need to read it. Just look at some of the data. There were 4 head-to-head trials conducted with oral semaglutide. As you can see, Pioneer 2, 3, 4 and 7. In Pioneer 2, oral semaglutide fought with empagliflozin. In Pioneer 3 and 7, oral semaglutide fought with sitagliptin 100 milligram. And in Pioneer 4, oral semaglutide fought with liraglutide 1.8 milligram. And here is the result of these 4 head-to-head trial. Again, the blue colored bar, the largest tower belonged to oral semaglutide. This is in terms of HbA1c lowering. You can see hovering from 1.2 to 1.4% in these trials. If you look at the body weight reduction, again oral semaglutide in these 4 head-to-head trials had highest weight loss compared with either empagliflozin, of course with sitagliptin, and also with injectable liraglutide 1.8 milligram. This is the data of 14 milligram oral semaglutide. Now, when you combine the composite of both body weight and HbA1c reduction, so this is the composite of HbA1c of more than 1% with a weight loss of 3% on the dual composite, looking at oral semaglutide in these 4 head-to-head trials, the best reduction of both HbA1c and body weight was with oral semaglutide. So this concludes the answer that amongst the available anti-diabetic agent, especially in our part of the world, the oral semaglutide has best HbA1c and body weight reduction. There is no, question about that. So the third genuine question is, can oral semaglutide compete with the injectable sema? There is no randomized head-to-head trial between oral sema 14 milligram and injectable sema 1 milligram once weekly. So how to make this data trying to compare between 2 molecules? So we published this paper last year looking at the weight lowering potential of both oral semaglutide and injectable semaglutide. Please remember, there is no head-to-head randomized controlled trial. So the only evidence which we have is to look at the indirect trials that compared oral semaglutide versus placebo and injectable semaglutide versus placebo with a similar background HbA1c and body weight. That will give you an indirect evidence which one is, doing how much is the efficacy between 2 agents. So if you look at the 5% and 10% weight loss, people with type 2 diabetes, those who achieved more than 5% and 10% weight loss in their respective placebo-controlled trial with a similar baseline body weight, you can see there is hardly any difference between oral semaglutide and injectable semaglutide. You can see in Pioneer 1, 44% people had a more than 5% weight loss, and so was in the Sustain 1. Despite that, in Sustain 1, the baseline body weight was larger. Again, if you look at the 10% weight loss, the oral semaglutide had a similar proportion of patients with 10% weight loss compared to injectable semaglutide. So this is indirect evidence from the RCT. Now recently, there were many real world studies that looked into comparing oral semaglutide to injectable semaglutide. So again, we published this paper last year. We systematically reviewed, is there any trial that compared oral semaglutide to injectable semaglutide, and we could see that there are 3 good real world studies. Why I said good? That these are propensity matched real world studies trying to compare head-on oral semaglutide to injectable semaglutide. So this is a busy slide just to make you this data into a graphical presentation. There are 3 real world studies that compared oral semaglutide to injectable. These all are international studies. You can see one from UK, one from Italy, another is from Croatia. Now if you look at the body weight reduction on your right hand side and HbA1c on left hand side, there was hardly any difference between 2 drugs. Although, you can see in some bar there is little bit change, but from the statistical point of view, it wasn't significant. In some of the trial, oral sema was better than injectable sema. In other trial, injectable semaglutide appears to be better than oral sema. But from the statistical endpoint, there is no difference between 2 oral and injectable formulation of semaglutide in terms of body weight and HbA1c. Having said that, this is not a hard evidence. We need to conduct a head-to-head trial to really say that both are equal to each other. However, people looked into what happens to plasma semaglutide when you give it through either oral route or injectable route. So this paper came from a Daniel Drucker's lab. They actually measured the plasma serum semaglutide concentration in people who took oral semaglutide in the Pioneer trial and those who took injectable semaglutide in the Sustain program. And when they plotted the graph of plasma semaglutide exposure after taking orally or injectable, they could see that 1 milligram of injectable semaglutide has a mirror image plasma semaglutide exposure to 14 milligram oral semaglutide. This suggests that regardless of the route which you are taking, whether it is injectable or oral, the peak plasma semaglutide exposure remains same. So therefore, the outcome should be likely same. Now this will translate into then, what about the cardiovascular benefit? Does oral semaglutide have a similar cardiovascular benefit like injectable semaglutide? So let's shift gear to now from HbA1c, body weight, to cardiovascular. So if you look at the GLP-1 and cardiovascular space, in next 4 minutes I will finish before time. These are total 9 cardiovascular outcome trial conducted with GLP-1 RA after the 2008 US mandate, of which all the trials result is published except the sole full data, which will be presented on 29th March at American College of Cardiology. If you will be awake, it will be exactly presented at 1:30 midnight on 29th March. You can see live if you are registered to ACC. Now, when you look at these published data from all the CV outcome trials, starting from, remember, ELIXA to Sustain to Leader, all these trials pulled together. So this was a meta-analysis done from all the trials barring the sole trial, because the data is not published. So the data from the pulled 8 CV outcome trials of GLP-1 is published in Lancet Diabetes and Endocrinology, Nabil Sattar and group from UK. And if you look at the CV outcomes on your left hand side and in your right hand side, BG slide, no need to read. Look at the diamond, all blue color diamond, all left to the unity, suggesting clear cut benefit of GLP-1 in terms of cardiovascular benefit. It's not only the reduction in 3P MES or MI stroke, but also on the mortality, be it CB mortality, be it all-cause mortality. So both CB death and all-cause death, prevention. So that brings back to oral semaglutide. Manoj talked about Pioneer 6. Interesting part. If you look at the Pioneer 6, if you look at this Kaplan-Meier curve, there is a clear difference in the graph with both placebo and oral semaglutide that translate into 21% reduction in the composite of 3P MES, but it did not achieve a statistical significance. The reason being that Pioneer 6 trial was not meant to look at the cardiovascular superiority. The Novo wanted to prove it is a neutral drug and let's sell into market. And that's why they went for a cardiovascular safety outcome trials through Pioneer 6, because this was pre-decided that if you want to do a superior cardiovascular outcome trial, we will do the sole trial. So please remember that oral semaglutide is one GLP-1 that has undergone 2 cardiovascular outcome trials. One Pioneer 6 to prove safety and another one sole, which I will show you, to prove superiority. And therefore, the Pioneer 6 was only intended to look for CB safety, and they achieved that target. Now, reason is, which I am trying to put your thought little bit when you go home. If you look at the Sustain 6, you know that injectable semaglutide had largest 3P MES reduction ever done with any molecule in the planet, be it a SGLT2 or GLP-1. Only Amplitude O matched with Sustain 1, Sustain 6 in their CB outcome benefit. So 26% reduction in the semaglutide injectable. But if you look in Pioneer 6, it was also 21%, but that did not achieve a statistical significance. Now this both Kaplan-Meier curve looks mirror image to each other. Then why one was positive and one was insignificant? This is the lesson I'm going to tell you tonight. Now here is the answer. If you look at all the trials done with, this is a very easy way to present you the data. It's not a hard statistics. Whenever you are looking at a CB outcome trial, always look at the absolute benefit. So the second last column in front of you. Now if you put your attention a little bit, you can see the Rewind trial done with dulaglutide had only 12% reduction, but it was statistically significant. If you look at the absolute difference, means number of event between the active drug and placebo, it was only 0.3. But in Pioneer 6, despite the difference was 0.8% better with oral semaglutide, and it was 21% reduction in 3P MES, it didn't achieve a statistical significance. The answer is very simple. Look at the number. If you do not increase the number, this p-value will not be significant. That's a simple reason. But if you look at the evidence on absolute difference, they very clear that I will take next 30 seconds. The Pioneer 6 has a better, Kaplan curve than the Rewind trial, but one become positive, one did not. So let's not put brain into that. Look into a superiority trial which has been planned and already finished and now going to be published. The SOUL trial. The SOUL was different from the previous GLP-1 trial, that it was after Rewind. It was the next GLP-1 CB outcome trial that was planned as a superior outcome trial. So before the match you said that India will win against Pakistan, and the umpire said that if you make such a rule then your entire target is different. Entire statistical calculation is very difficult. So the SOUL is different from the previous GLP-1 trial, that everyone had a CBT. That is not unique. So even in the SUSTAIN 6 everyone had established cardiovascular disease. But it contains the largest number of patients from India with regard to any GLP-1 trial till date. You can see the people in this trial also had a kidney disease and significant number with a heart failure. Now why this is important? Because these patients must be receiving SGLT2 inhibitor. Today this is a mandate that if you have got a patient with heart failure and CKD and if EGFR is more than 20, you must prescribe SGLT. So in this trial, nearly 50% of the patients were on SGLT2 when the trial ended. In earlier trial, maximum data is with amplitude with 15% people on. So once the trial is going on, over the time, people are getting more SGLT2. And lastly, if you look in this trial, this is a trial where primary outcome is cardiovascular and secondary outcome is kidney. So that's very interesting. So like you remember in the FLOW trial, primary outcome was kidney but secondary outcome was heart. In the Figaro DKD trial, the primary outcome was heart and secondary outcome was kidney. And here is the top line result. There was a 14% risk reduction. Please remember, in the LEADER trial it was 13%. In the Rewind trial it was 12%. Here in oral semaglutide SOUL trial, at the top of SGLT2 inhibitor, there was additional 14% reduction in the composite of 3 PMS. Ladies and gentlemen, the last slide to tell you, we are waiting for this result. But what is interesting to look at this trial is that the secondary outcome is the kidney outcome. And it has been put in a statistical hierarchical fashion that if you achieve the superiority of 3 PMS, then I will look for the kidney outcome. If it's positive, then I will look for the cardiovascular death. And finally, this is the only trial at the moment which is looking for your peripheral vascular disease outcome. Please remember, SGLT2 has got a problem with people with peripheral vascular disease, where GLP-1 is considered to be the good agent and perhaps to prevent peripheral vascular disease. So one of the endpoint is the peripheral arterial disease. We are waiting for 29th March, 1:30 a.m. We will meet to look at the result. Thank you very much for your patience listening.